mainly from the standpoint of how you manage them. And, the first thing is common sense, and I think there's not a lot of, it's either my eyes or I don't know what, but it looks blurry to me. This is my eyes. Okay. So, this is a guy that works here. He's a physician. And he's famous for, like many physicians, just hallway consult you to death. So his main complaint is what he calls severe pain here in his calf. He has constant tightness. His foot and ankle are obviously swollen. And he was kind of a trendsetter. You know how for a little while people were wearing flood pants, like the pants like they're up here? Well, he did that like a couple of years beforehand. And so he comes hobbling into my office with his flood pants on, and you can see how swollen his leg was. Oh my gosh. So that's why I was able to pick up on this so quickly when he walked in. So his main complaint is he is really struggling getting around because of his sharp calf pain. He's fearful that he has a DVT. And his day-to-day activities when he's on call, which is every 6th day, he's a cardiologist, he's all over the place. He's going to the ED, back to the clinic, up to the hospital, and as a result, he is off work because he doesn't feel he can do that. Now, he could have sat at a desk probably and done desktop medicine as long as he could put his leg up now and then, but they just put him off. He has 2 kids. He has a dog that he walks every single morning. He can't do that now. He jogs on the treadmill 4 days a week at his club. And his big fear is his son's bar mitzvah is 6 weeks away, and he's supposed to do some type of traditional dance, which apparently involves a lot of calf activity. So, has anybody here been to a bar mitzvah and seen the parent, the father dance? Okay. I haven't either. So you get from this, there are some timelines, right? I mean, they're his timelines. But, God's sakes, sorry. So here's his history. Take a peek at it. What do you think about this? What are some questions you just might ask as you're cruising along?
Is there any bruising?
Okay. But what about his method of injury? Is there anything you want to,
Yeah.
is there anything odd about this?
I guess, like, was anyone around him, or did it feel like he was kicked and then fell down? Because I feel like a lot of people say that's how it feels,
Yeah.
right? With
Well, particularly with an Achilles tendon rupture, they feel like somebody kicked them in the back of the leg. With calf tears, there's a French term for it, coup de foie. It's crack the whip. And people have a sense of like they've been whipped, because it's really sharp and they feel a pop. It's like, that's why they call it food fucking. But he didn't have that. He just, you could have said, well, did the sharp calf make you fall to the ground, or were you going to the ground? Were you diving at the base? I didn't really, he's not an athletic person. Probably shouldn't have been playing because he's fragile. But the thing that I didn't understand is, he says, then while standing in center field, so he walked it off. He was able to, because I had a calf tear a few years ago and I couldn't walk it off. It was not a fun experience right afterwards. So he said, later I was so embarrassed and I didn't want to quit. And so he's out in the field and his legs started cramping so bad that he just sat down. And everybody's like, well, what are you doing? That's more embarrassing. But so he needed a ride home because it's his right leg and he couldn't drive. So pretty severe. And then he does what most people do, which is the opposite of what you should do with any type of muscle strain or tear, is he took non-steroidals, which anticoagulates you, and he took a pretty healthy dose. And so next morning, of course, he's swollen, he's painful, as most people are, and he called in sick. And then he came in here and saw a sports medicine doctor, who told him to use a rolling pin on it, which, sounds great for a tight muscle, but not one that's acutely injured. So he's listened to the guy. He says, I keep doing it. It's horribly painful, but I think it's making me worse, but I keep going. So you ask him about it, you look at his general health, he's a very healthy person. Otherwise, are there any clarifying questions you want to make sure that you've covered with someone who's had a lower extremity injury like this?
Maybe see if he's like giving way on his knee. Does anything feel like unstable on his knee or clicking, popping? Maybe injured something else too, just in case. But
what are some things that you would ask that are not necessarily medical screening questions, but just things that might cause you more concern, things to clarify? Yeah. So, and then, do you have any tingling or numbness in your foot? Because DVTs can happen, but then also in rare instances you can get a compartment syndrome. If it's a bad enough tear and the blood goes into one of the compartments, we'll talk about that in a few minutes, but there's not a whole lot to ask somebody like this, except maybe that, if you haven't already clarified that. When you're taking the body chart, and he was so clear about his body chart. This is where it hurts. He was prepared to kind of tell you everything, and so there's a chance of kind of missing. Missing things. So this is not very typical. He had. This is him in ortho. So he's kind of made the rounds already, and they took a picture of his foot. One of the PAs that he saw down there. And so yes.
Oh, sorry. Quick question on like the DVT and the compartment syndrome. We saw a lady in the ED over the weekend who had a really bad humerus fracture. I mean, she's 90 years old. Totally displaced, like it was like this, and they're not doing surgery, but she was getting so purple and black and blue that I was like, isn't there like a risk of some of those things, like with somebody that elderly with that much bleeding? What else would happen with that potentially, or would we need to keep an eye out for?
The biggest concern I think would be, does she have a venous tear? Or if you have somebody with a lot of extremity swelling, it could be a venous tear, or they could actually have an arterial tear, and then they bleed into the extra, or the tissues, the interstitial tissues, and then they get swollen. So that's the bigger concern is with humeral fractures, or like humeral head fractures even,
Yeah.
and dislocations in the elderly. The compartments can happen. I mean, you can get a compartment syndrome in your forearm. So I would imagine, you know, if she's pulseless and things like that, that's concerning.
Okay.
But if she has decent perfusion distally, that's probably something that you don't have to worry too much about. Were they discharging her or admitting her?
They were keeping her in skilled nursing. I was just wondering what else they would do to control some of that bleeding. She's also on blood thinners, but
Oh.
yeah, so it would just, X-ray looked horrible. Just was starting to look really discolored, and yeah, this poor lady. So I was just, curious if like there's any, other things they do to kind of address.
Well, I think if she probably, I would imagine they might have a general surgeon or a vascular surgeon look at somebody like that, but I don't know.
Yeah.
I would definitely answer that. Sorry. So typically, people who tear their calf, you know, if they happen to lay supine for any period of time, they'll get local bruising pretty quick. If it's a substantial tear. For him, he didn't really have, he had kind of like a little bit of a hew to his calf, but he bled down through the compartments into his foot, which I think is not really common. Not early on, not in 8 days, but he has continued to take Motrin. Nobody told him to stop taking Motrin, so he's kind of, this is happening partly because of him. So he's walking with his hip externally rotated. And the function of that is what?
Relief,
Yeah, it was in the dorsiflex, right? Yeah. And he has pretty tense edema in his calf, in his foot, his ankle. And his active, this is not somebody you're going to examine in a lot of detail, right? You just look at the basics. So his dorsiflexion, he's minus 20 degrees. He's got normal plantar flexion for the most part. His knee motion is okay. His straight leg raise, I just did this for posterity, but it's very limited because he's obviously his neural tissues are affected by this. One thing that kind of concerned me, his foot was ice cold. So something to, keep an eye on. What you don't see here is, I did do, can you squeeze somebody's finger or toe?
perfusion.
Yes. And he had good capillary perfusion, but his foot was really cold. And maybe that's partly sympathetically mediated too, because of the pain he's having. So when you're looking at the zones that you're interested in with large muscle tears of the calf, it's either, of course, Achilles, the musculotendinous junction of the Achilles, and then the soleus, which is palpable medial and lateral about mid-shaft, and then, of course, the medial and lateral head of the gastrocs. With the medial head being the most vulnerable. So here's what I did with him. I had a long discussion about the short-term plan of care because his goal is to get to his son's bar mitzvah and be able to do whatever this dance is. And we talked about soft tissue healing, and I talked about where he probably was at 8 days, because he doesn't understand the soft tissue healing paradigm. And then we had a healthy discussion about using assistive devices, because he had already talked to orthosurge, plus a PA and orthosurge, plus a sports medicine, and they said you don't need assistive devices. He had asked them, do I need a cane? Should I use a cane? And they said, no, you just be careful the way you're walking, you don't need that. So he was not a real big fan of using crutches, of course, like so many people aren't. And so, I told him ADLs, he probably would be fairly normal, but do you think with the amount of pain that he has, he would have a normal heel off by Maybe if he was 20-some years old, it would be different. And then as far as jogging and doing things that are more recreationally oriented, probably 12 to 16 weeks, it's gonna be a while. And you set the stage. This is a good thing prognostically, and, you know, unfortunately, when you treat physicians or other people who doctor shop, basically, you have to be ready to defend the things that you're saying. And the easy way to defend it is this is just my personal experience. That's what I'm sharing with you. So you don't have to listen to me if you don't want to. I used to take things so personally and like, oh my God, I can't believe this person's not listening to me. And now I just think, you know what? It's your life. If you want to make yourself miserable, it's your call. And we only can do so much. If it was your kid or something, that would be different. You'd be more invested. But I think when it comes to your average individual, you just do the best you can. And so I moved him into bilateral axillary crutches. I said, if you want to use your foot for balance, great. But otherwise, don't use it. Just let it rest. We'll see what you're like. Because, you know, with people like this, you know they're coming back to talk to you in 2 or 3 days anyway. I put him on the game ready. I debated this. I thought it would be great for him. I thought he's going to show up every day, drive over from Walnut Creek and want the game ready, but that wasn't the case. And I taught him how to do a funnel wrap, which was kind of a disaster. I think you know what that's like. You do a nice funnel wrap and then you have them practice it. It's hard for a patient to do that. But I did teach him. And then I encouraged him to move his ankle a lot within his pain-free range. Just, you know, if you could draw out a movement diagram or just a line and say, you hit like a little bit of a stretch here, that's where you go. You stay there for a couple of seconds and then go back out of it. This constant movement's going to help with your swelling. It's going to help with the scar tissue laying down, which is actively happening by 8 days. And so you give them, this is the hard part, you got to take the time to give them the rationale of what they're doing. I think patients really appreciate that, as we do, when a physician takes the time to explain things to you. And then he was like, do I do heat or ice? Somebody told me to do heat, somebody else told me to do ice. I said, do both. You know, and I think you could make a case for that. The heat will help kind of open up the capillaries, get things moving, and then the ice in theory will help shut that down and maybe help with re-swelling, but also help with the muscle spasm. That's the main thing that ice is going to do. You guys okay with this, like, first day? Is there anything else you would recommend? Okay. So here's my assessment. And there's a lot of, just so you know, if you look at the literature, there are a number of classification systems for calf tears. The problem with them all is that they're all based off of MRI findings, not function or severity. So I gave him this, I think it's a type 2 tear, medial head of the gastroc, he's in the proliferative phase. I could have said he's severe. Probably you could say irritable too, because you're not going to do much with him, but severe, the severity would stop you from doing much with him. And then I put some other comments, he must comply in order to move forward. And I put in here that he's pursuing too many options. I didn't care if he saw this in the note, he probably wouldn't look at it anyway, but I thought if he does read it, he'll go, oh, yeah, he's probably right. So, and I did talk to him about that. I said, man, you have to not doc shop. I can help you with this, but you're gonna just have to be patient. So the downside is, you know, you walk down cardiology hallway, that's where everybody's cruising back and forth. And so it's easy to say, hey, what do you think about this? So I said, just come by in a week, and then my only plan was to just make him stretch a little bit harder, hopefully in a week. You should be able to do that by day 15. And I said, if you can get onto a stationary bike, if you really want to go to your gym, get on the bike, ride with a heat, you know, to get people to not activate their their gastroc and soleus muscle. You almost have to ride with your heel on it. And most bikes have toe clips. So I did tell him that. So you can put your foot in that toe clip and you're gonna be kicking on that foot, and it's really hard to otherwise do. So he ended up not doing that. I don't think he ever used the bike at all. Here's a classification system that is very detail oriented. And so it ranges from, these are ultrasound findings. There's some that are based off of MRI findings, but it just bases everything on using an ultrasound to define what the classification is, and then your estimated return to whatever activity it is gonna be. And these numbers are misleading, I think. For a type 2B, it's 28 to 35 days, which is 7 weeks. This one is complete tear, full thickness, 6+ weeks with individualized rehab. Well, when you have a full tear, there's 2 things that you can do. One, you can have surgery, okay? Because if, let's say you look at somebody's medial calf and they just came in your door like 2 days after an injury, and they have basically a shelf, like a cliff. That's somebody who's had a massive tear, and at the very least, it warrants a phone call to orthopedic surgery to see if they would be interested in consulting with the patient, particularly if they're athletic. They're somebody who is younger or is a higher level athlete. That this should be a consideration, but you can't wait for months for that consult to happen because the muscle gets retracted and then there's nothing they can do. The other thing about this is they tend to be less painful because it's completely torn off. And so there's nothing tensing that area. So these classifications, I think you could break into type 1, 2, and 3. A type 1 is probably macroscopic tears of the muscle, which are what we call a strain. A type 2, there's a defect in the muscle. And a type 3 is a complete rupture of the muscle. That's what I learned with hamstrings, calves, whatever the muscle is. So I think that's the way we have to think, but when you talk about estimated return to play, it should be based on their functional disability. We all know that if someone is like this guy, first of all, what are his attributes? He's got a good general health profile, right? That's an attribute. He doesn't have any diseases, not diabetic. But a downside is he's 47 years old. So his tissue's not as elastic as it once was. And he's not going to heal as fast as somebody who's in your age group or people who are younger than you. And so this estimated return to play or activity, it should really be based on more what you see functionally. And somebody with a loss of a minimum of 20 degrees of dorsiflexion, he's got a pretty significant injury. And even if it is not a huge defect, that small defect that we palpated probably bled a lot, and that's what's irritating his tissues because, what did I write in here? I think it was like a nickel-sized, the size of a nickel. I use coins, dimes, or we can say pencil head, dime, penny, nickel, quarter, $50, I suppose. Anything bigger than that's probably going to be a full thickness tear. So he was very concerned about a DVT. So he went and just walked into the ultrasound department of radiology at lunch, found somebody to look for a DVT, and then he also said, hey, can you look to see if my muscle's torn? And so what they came up with was, yes, it is torn, medial head tear. He's got a lot of fluid collection. They didn't pick up that there's a soleus tear, but there was a soleus tear as well, as we'll see in a few minutes. Our ultrasound techs, just so you're aware of this, that are down in the radiology are not musculoskeletal experts. So when they do, they capture images, they're not that skilled in it because they don't do it. They look for they're doing systemic studies, not muscle studies. I don't know how good Krista Matko is. She has an ultrasound machine in her office, and she does ultrasound imaging on a lot of the patients that come through the door. I think Steve McGrath does a fair amount too, but he reserves those for patients who have had surgery and then maybe they've fallen, and he's worried about them re-tearing. So he'll do an ultrasound study on them to see if they re-torn or repair. But I don't know if he uses it beyond that. Okay, so here he is, 15 days. He says, I'm using the crutches, but not at home, and I came back to work, and I'm not using them at work. It's inconvenient for me. And plus, you know, I was told I didn't really need to use these. And I'm like, oh my gosh, you know, okay. And so it's hard to drive to work. He's doing his range of motion exercise. He got a copper sleeve because better than the ACE wrap. Like, this is great. You know, you and Brett Favre now have the same copper sleeve. And so his physical exam, his range of motion is the same. He's got pretty bad edema in his foot still. I ended up doing lymph drainage on him, so it's not really lymph drainage, it's just tissue drainage, but it involves you get distal, what Corey's doing, and you just put circumferential pressure and you're sliding up, and it is very uncomfortable. And he was like, are you kidding me? He was complaining about his swelling, and I said, okay, you know, I can help you with the swelling, and it really makes a huge difference. The only thing is, as soon as they have a dependent position for a while again, it will fill back up. And so you have to tell them to keep doing their elevation and active movements. So then I also told them, I said, don't come back if you're not going to use the crutches. There's no point in seeing me because this is just, I'm going to have to see you from now till the end of the year because you're not willing to listen to me. So he promised me he was going to use the crutches. And you know, of course, the plan would be to move him to a single crutch as soon as he's a little less painful. But he, of course, did a drive-by in orthopedic surgery. This is funny stuff, but you're going to have patients like this, and you're going to go want to pull your hair out. So he has an MRI, and of course it shows, here's this tissue here, this white area here is all edema. All this is edema from his tear. You can see it actually kind of between the fasciculi here. And it involves the soleus muscle as well. And so it doesn't say much more than agree with the ultrasound findings and add in the fact that he's got a soleus tear, and that, of course, is in his head. It's like, okay, so how is this different now that I have a soleus tear? Like, do you know what the two muscles are? You know, and so he calmed down with that. But his thing was, you see my MRI, I saw ortho yesterday, and he just stopped somebody in the hall, and then they said, get off the crutches, use a cam boot. So they wanted to give him something because they want to get rid of him, right? And then they said, let's get you an MRI, which he got immediately. He got it like same day. And they said, well, we'll see if a surgical fix is needed. Of course, they didn't examine him, they just talked to him and walked it down the hallway. And he said, then, by the way, I felt so much better after the lymph massage that I did. So, physical exam, same as before. We did the lymph again. He actually asked for a towel and covered his face, and he cried. I did the game ready again. I had him start to push into, he was able to now push into dorsiflexion and tolerate it better. And I said, use the crutches, don't come back, I need it. And the plan was to see him in 2 weeks. There's nothing else to do right now. You have to just rest this and heal up. And then I continued to see him every couple weeks for probably the next 2 months, which involved, you know, a lot of soft tissue work, getting his motion back, getting him strength. I got him strengthening his hip abductor because it was very, very inhibited. But it was just your basic rehab technique. And so we'll go through a couple of the soft tissue techniques that I did on him today. And I think, you know, you'll use them, particularly with your post-op patients and stuff, but you'll use them with calf injuries as well. So if you look at the literature for incidence of calf tears, you know, this is underreported information. If you probably went into the Division I NCAA database, you would see much higher numbers because they enter everything. And so we're talking about grade 1s, which probably in our world, they don't even get reported. It's really not until it's more demonstrable with tear. So in Division I collegiate soccer players, the incidence is 3.6%. I would say it's probably higher than that, but that's because they're talking about bigger deals, not just grade 1s. Probably what you're going to see most people with, this is what we call the scourge of the 40-plus-year-old intermittently active male. But females also. And I think when we get more data from pickleball injuries over the next decade, you're going to see this kind of be more equivalent. But it really has typically been guys who don't exercise anymore trying to go back to sports like softball or something where they're running and they're pivoting, tennis, and you know, just doing things intermittently. And this coup de foie is that crack of the whip I was talking about. So the medial head is the most common, and honestly, I think I've seen some people that have defects down where the septum is, where the medial lateral head come together a little more distally, but I've never seen a lateral head complaint, I can't think back of it. 17%, now this is based off of MRI data, have an associated soleus strain. MRI is used if there's a question, like not in our case, but like, is there a question that surgery might be warranted? And I do think that if you have an elite athlete who's, you know, young to maybe your age group, a little bit older, you need to actually consider that if you have a major tear. The literature also says this: non-steroidals should be completely avoided for 4 days. And if people use non-steroidals, most people don't even know that. And really, our physician colleagues don't think about this stuff either, as you know in this case. But it just causes them to bleed like crazy. And the last thing you need is a lot of blood that particularly becomes like a hematoma. Then that's a problem. So complications, we kind of talked a little bit about a deep vein thrombosis. It's particularly concerning, like if you, let's say you're traveling with an athletic team back east and somebody has a substantial tear and they have a lot of swelling, you're now flying and a DVT becomes a bigger concern. You have to make sure that they are wrapped up nicely or they have some type of compression garment on, that their leg is elevated as much as possible in that plane and they're moving their calf back and forth. But DVTs, I mean, when you see these calf strains, you look at them and go, holy moly, I wonder if they do have a DVT because they're so, like his was so tensely swollen. But when you see enough of them, it's like, okay, well, I'm not going to be jumping, you know, leaping off a bridge here and saying, we got to get you an ultrasound, but it's something that you have to consider.
The flying you mentioned within the first
Well, probably within the first week, I would imagine. But I think just for the standpoint of being comfortable,
Yeah.
I think because you're still swollen after a small tear, even in this case, doing that is important just for comfort level. But there's some risk then when you do it really well, I would imagine. And that even is what, goes for like knee injuries and stuff, and you have a knee effusion, that's a possibility as well. I remember flying back with a soccer player from North Carolina. We were back there in this tournament, and he tore his ACL, and he got a lot of calf and foot edema because he had such a bad effusion. So, like right before we went to the airport, we were using a thing called lymph drainage on him at that time with this thing called a MENS unit. It was a microcurrent unit, and it would help. It was amazing. It would get the edema out, even help with the effusion, and then wrapped him up tight and hoped for the best. It can be a concern. And then there's the acute compartment syndrome. This compartment syndromes are very rare in this kind of a situation, but it is a possibility. And then if somebody says, yes, I have tingling in my feet or my foot, then it warrants probably at least having an ultrasound. But the orthopedic surgery department will just do a compartment test. They have a thing with a needle on it and a pressure gauge. It's not super painful. They slide it into the anterior lateral compartment and the posterior medial compartments to test for increased pressures. And then if you have that, you have to have a fasciotomy or risk necrosis, tissue necrosis, and all the good things that come with that. Not recently, but some time ago, I had a patient who had exertional compartment syndrome, but it started becoming something that was not chronic is not the right word, but it would last for a couple of days after running. And before doing the compression test, they did an MRI in her lower leg because they were just thinking, what is it anatomically with her, and does she really, have this fluid collection? And she certainly did. They got it done after they had her run, and then for her, they put her on. They did a pressure test that was normal. There's no way this could be normal, so they had her walking uphill on our treadmill in the PT gym, and you can put basically put that needle into the compartment, and then you have the monitor, you tape it all on, and then the monitor's taped to the leg, and then you're watching this thing as they're exerting, and she had pressures that were off the charts. And then, there's this whole kind of nebulous category of myositis ossificans. So myositis ossificans can occur from blood trauma. And that's actually the correct term for that. You may remember this from PT school. It's called dystrophic calcification. You take a helmet to the thigh, or you get hit with a softball, and that area can become calcified. The next steps on that is you take a helmet to the thigh, and you end up with a hematoma that's deep underneath the quad musculature, and that hematoma either can start to crystallize or it can calcify over a long period of time, which is not the same thing as this, but it is kind of a subcategory of it, which is why oftentimes they'll drain hematomas when it's very obvious that an area is staying raised up. And then myositis ossificans is probably more commonly we see this post-fracture from an elbow fracture. You get this myositis area down on the ulna where the brachialis inserts. That's a real common place for myositis ossificans, but we don't think about it when it's just injured muscle usually. And so you have to kind of give that some consideration, particularly if you see someone way down the road and you're palpating their calf muscle that they're continuing to have pain with and it feels hard. If they haven't had a plain film, then they should probably have a plain film with their lower leg at that point. Maybe penile lateral should cover it. And if you see calcium deposits, then at least that helps you with your prognosis with that patient. Okay, so that is it. But I, you know, we didn't really have much of a case discussion, but I just wanted you to, if you hadn't had experience with calf tears, you'll have them, for sure. I think the biggest take home would be make sure they do load management that's appropriate. And you have to kind of match up the degree of severity and disability that they have with the amount of offloading. And if, you know, if he kind of walked in with a subtle limp, I'd say, here's a single crutch. But this guy needed probably, you know, a good 4 weeks of non-weight bearing. And, you know, I just said, if you walk by your orthopedic colleagues and they say, where are you using those? Just tell them to suck it, man. It's your leg, not theirs. And one of our orthopods tore his calf. He hadn't done anything athletic in probably forever. He wasn't a very athletic person. I think he was playing volleyball at a family reunion. And he had a pop in his calf, and he was on crutches for like 8 weeks. But he started in a cam boot. And he went on for a couple weeks in a cam boot. And then he came up and he saw Sherman, and Sherman was like, man, are you crazy? You got these crutches? He did it and had a pretty good result. So, I think that's really the key. Because cam boots are not offloading.